Good evening. This is a presentation both on the diagnosis as well as on the current management of eczema. It's of considerable interest and use to many doctors who deal with this situation every day of their working lives. So here we go with our presentation now. So the diagnosis of eczema has been updated in October 2023 in line with the assertions of the British Association of Dermatologists. And so the NICE guidelines CG57 is now updated. So we go on to the PowerPoint presentation as to what eczema is. Eczema, by definition, from the Greek word exene, is to boil over. And so it related to itchy, red, dry skin with ooze, transudation, exudation, blistering, crust, scales, and it became thick with time. We know of it now as a condition belonging to atopic dermatitis, which relates to chronic itchy inflammatory skin present usually in childhood under the age of 6, with exacerbations and remissions from time to time. So what are the theories behind the causative factors relating to eczema? We know that the primary function of the skin is to act as a barrier against loss of water and to block exogenous irritants and allergens and pathogens entering to the subcutaneous tissue. That being the primary function of the skin, it usually serves a very good job in its present uninfected, disease-free status. There are two separate theories which suggest various causative factors. The first one is that which relates to complexities between genetics. And we know that family history is high as one of the associated features in eczema. Immunological factors, because it's an IgE-related condition which manifests its symptoms that way. Environmental factors, such as contact dermatitis, allergen, irritants, carpet mites, and so on and so forth. And when the skin barrier becomes dysfunctional, or if the immune mechanism which offers protection starts abnormally producing IgE, and there is receptivity for colonization by bacteria. So that was the first theory. The second theory is mainly genetic in nature, that if there is an aberration in the filaggrin gene, then it can cause reduction in the defensive mechanism of the skin barrier, causing eczema. The other theory is that the T helper cells become excessive as far as Th2 is concerned, more than Th1, and this leads to excessive production and distribution of IgE from mast cells. And this is associated with producing the exudative form of eczema. Clinically, we know that 70% of patients who have atopic eczema have a positive family history. So what are the triggers which can cause or contribute to making eczema? So there are many contact chemicals such as soaps, detergents, cleaning up liquid, animal dander, hair from cats, carpet mites, extremes of temperature, rough contact with the skin of clothing, which includes clothes as well as beddings. Sometimes indirect triggers could be food and stress. The immediate effect of eczema would be to produce redness, itching, urticaria, angioneurotic edema, and also some systemic effects such as those which relate to excessive production of GI tract hormones or respiratory system, whereby it can cause constriction in the reversible passages and also produce shortness of breath. It can also produce sequestrated fluid volume lost from the network of circulation, leading to collapse. There are delayed effects of eczema which can cause itching, flare, and gastrointestinal disorders. In the UK and in the northern part of Europe, it's a common condition affecting 10 to 30% of children with no gender preference and no ethnicity. When one parent gives a positive family history, then the offspring would have a 60% chance of having an eczema. But when both parents have a family history of atopic disease or eczema, then up to 80% of the children born to such parents are likely to have eczema. So what is the complication of atopic eczema? There is higher preponderance of bacterial infections in the rash of Staphylococcus aureus. There could be viral involvement leading to herpes simplex virus, causing groups of vesicles which are widespread and cause punched out erosions. There would be fungal involvement such as annular lesions of fungi present on various parts of the body, which are warm and sweaty. There are also much less talked about psychosocial disorders. So someone suffering from visible and symptomatic eczema would have depression, distress. A young school-going child would have behavioral problems, lack of confidence, parental dependency, peer bullying, poor self-image, sleep disorders. So where does atopic eczema go on to? It is usually episodic with occasional flare-up, but in 74% of children who have symptomatic eczema at the age of 6 will have eczema in adult life. In general, 65% patients with atopic eczema by the age of 6 will have regression, and by 7 years of life, it would have improved spontaneously. 30 to 80% of patients who have diagnosed atopic eczema will develop asthma. And this is described as atopic march. So the diagnosis of atopic eczema is largely clinical. It can be confidently said that if there is no itching present in a skin lesion, it is unlikely to be eczema. We should look for diagnosis elsewhere. It affects infancy, young childhood age, and it is usually episodic with relapse and remission of uncertain durations. There is usually a positive family history of atopic disease, usually eczema, but it could be seasonal breathing disorders, hay fever, or asthma. There are usually some trigger factors which can be identified as leading to the symptoms of atopic eczema. These should be avoided. So what are the examination findings in eczema? Lesions are present usually in the flexural region, such as in popliteal fossa, cubital fossa, in the region of groin, and also where there is more sweat and increased rash as a result of sweating and congestion, such as in the submammary space. However, in infants, although face, scalp, and extensor surfaces are usually affected, the nappy area is spared, possibly due to more attention given during nappy changes on a regular basis. With acute flares, there would be vesicles, erythema, and there will be no geographism. So there will be indistinct borders. Chronic eczema leads to thicker skin, and this usually manifests itself in the extensor aspects of the hands, but it could also involve the palmar aspect as well. If the lesions are weepy, they eventually crust over or lead to development of papules, at which time bacterial secondary infection is quite common. The diagnostic criteria in CG57 of NICE suggests that if there is itching present and if there are three more features, such as vesicles involving flexural or extensor surfaces predominantly, or if there's a rash in an infant under 18 months of age, or if there is past history of a rash present on cheeks, if in general there is history of dry skin predating eczema, or if there is asthma, allergic rhinitis present in less than 4 years of age. So itching plus any of the three will lead to a strong diagnosis of eczema. Often the psychological impact on a child or on a young person is not getting as much of attention as the physical disease and disorder. There are certain identified triggers, the allergens being soaps, detergents, cleaning materials, cleansing agents. There could be irritation from clothing, bedding, pillows, from synthetic fabric, woven materials such as wools, and hair dyes. Other triggers could be that if a child is suffering from a bacterial infection caused by Staphylococcus aureus, then this can lead on to a relapse of a dormant eczema or can show eczema up as the first occasion finding. There could be inhaled allergens such as cat dander, dog hair, rodents, pollen from plants externally, extremes of temperature, drying of sweats on the body, which leads to irritation and itching, which leads on to scratching and then to infections. If there is concurrent illness requiring lying on bed for a long period of time with sleep disorder leading to brooding and scratching, the role of food-mediated allergy is controversial, but it relates to milk protein, egg protein, wheat, and so on. In the primary care, allergy testing is usually not needed. But if the treatment fails or if the symptoms become increased or become unresponsive to conventional treatment, then allergy testing could be part of the specialist referral activity. So the differential diagnosis of the rash of eczema could be with psoriasis, which has discrete raised borders, and it also has thickness and erythematous shape with flakiness and shiny silvery scales. Allergic contact dermatitis, which could relate to cleansing materials, soap and detergents. It's also been reported in doctors and nurses who frequently wash their hands in scrubbing or with iodine or chlorhexidine often. Seborrheic dermatitis, which is a red, sharply marginated lesion with greasy scales, but it also has dandruff-like skin flakes in the eyebrows or in the hair margin. Fungal infection, which is a kind of a tinea ringworm type of lesion, which is raised with central clearing, unlike psoriasis or eczema, or even scabies, which would have lesions seen in the palmar web space and also subungually as well. So how does one assess the severity of eczema? At the time of examination, there may not be any lesion at all, so it's a clear condition, possibly in remission, or the diagnosis is something different. If the severity is mild, there are some areas of dryness and some of itching and redness. If the severity is moderate, then it is usually dry, there's frequent itching, there is erythema with scratch marks causing excoriations. If the severity is actually severe, if the eczema is severe in its presentation, there would be widespread lesions on the body, incessant itching, erythema, oozing from exudation, and there may also be pigmentation along the rim of the lesion. Sometimes the skin lesion of eczema may appear to be infected with exudative lesion, with crusts, purulence, or pustules, with fever and malaise, with systemic effect of bacterial infection. Severity can also be assessed from the patient's perspective using the patient-oriented eczema measure, and this is POEM. In addition to Children's Dermatology Life Quality Index. So they could show the severity as it affects the individual patient. This assessment should also include the psychological impact of eczema, which is very variable and affects the activity of daily living, sleep pattern, school performance, performance in sports, and how a child copes with the peer bullying. Once eczema is diagnosed in the primary care, then nice quality standards suggest that there should be documentation of past and current treatment history, identify trigger factors, and how often they have been stepped care plan applied. Psychological well-being and quality of life should be assessed by appropriate methods. When moisturizers are prescribed, abundant and sufficient quantities such as 250 to 500 grams of emollient should be prescribed per week and monitored for its use, and it should be unperfumed. Uncontrolled symptoms and unresponsive children to primary treatment should be referred. Infants and young children with moderate and severe atopic eczema should be referred to the pediatrician for possible food and other allergy testing if indicated, bearing in mind that if there is symptomatology or suspicion of eczema herpetiformis, then the patient may require acyclovir immediately, and so the same day referral for admission to the specialist should be made. This was an update on how to diagnose eczema and how it presents itself. We should now deal with the management of the eczema. So the policy has been updated in October 2023 in line with the recommendations made by the British Association of Dermatologists. So we have already talked about the severity and its assessment of eczema. It is necessary to be reminded that the eczema could be invisible, it could be mild, moderate, severe, infected, and may have psychological impact on an individual young patient. The perspective of the patient can be assessed by way of their symptoms through OM. And I have mentioned below a link to see this and how visual analog scale can be applied with regard to severity for lesion, itch, and sleep. So a number could be given so that appropriate monitoring could tell us whether the treatment is working or the condition is worsening. So with regard to mild eczema, there are these two slides. There should be generous and frequent use of emollients. Mild topical corticosteroids such as hydrocortisone 1% should be continued for 48 hours after the flare ends. Self-care advice through personal education or leaflets or printed material from British Association of Dermatologists should be shared. If eczema is at a low level and mild but remains persistent, there should always be an annual review of the condition and of the prescribing, and also consideration should be given with regard to the patient's symptoms of referral. If the diagnosis of eczema is uncertain, or the condition is uncontrolled, or having around 2 flare-ups per month, or if the facial eczema has not responded to the given moisturizer and low-dose steroid, or if there is recurrent secondary infection, then a referral to dermatology should be made. Personal education of the patient is reinforced with leaflets printed via internet from the British Association of Dermatologists and many other organizations dealing with skin conditions. So, eczema herpetiformis, which is a viral-based condition which is generalized and causing many systemic disorders, is a medical emergency, and therefore immediate admission is warranted for antiviral treatment, fluid, and blood pressure control. But with mild eczema but not acute conditions, asthma should be excluded. Sometimes spirometry reveals presence of asthma, whilst the patient is unaware. One should remember that when there is remission of condition following treatment, then emollients should be continuously used for a very long time. And there should be avoidance of known and identified triggers and teaching and training to avoid scratching, which can reintroduce and reactivate dormant eczema. Parental advice should include not changing diet unless advised by specialists. Complementary therapies are not helpful, and these are homeopathic and various forms of personally investigated internet-based Chinese or Indian therapies. So they do not really offer any realistic long-term help, and they may have side effects. When eczema is moderate, such as eczema herpetiformis, patients should be admitted, and active control of the trigger factors and infection should be instituted. In this regard, moderately potent topical corticosteroids should be used, such as betamethasone valerate, 0.025%, or double its strength as 0.05%. Occlusive dressings can be applied as dry bandage, and they offer symptomatic relief and prevention of exogenous additional infection. If severe itching or distress is present in a child or a young adult, then prescribing initially non-sedating antihistamines may suffice, such as cetirizine, loratadine, or fexofenadine. Once potent corticosteroid topically is used, they should be stepped down in or after 48 hours if there is improvement, followed by educations in relation to avoidance of triggers and what to expect by the parents and by the patient. If the child has been diagnosed with moderate severity eczema, and if corticosteroids or antihistamines have been in use, then a review for corticosteroids in 3 to 6 months and a review for antihistamines in 3 months must be made. They tend to lose effect if incorrectly used or used for a very long time, and the change of treatment might be necessary. If the diagnosis is uncertain at the outset, with just controllable eczema, then routine dermatology appointment is needed. If the diagnosis is uncertain, then an urgent appointment is made. If there is facial involvement or if the eczema is causing significant psychological problems, then referral to immunology for allergy testing or pediatrics if food allergy is suspected should be made. Even breastfed or bottle-fed infants who have developed moderate eczema need to be referred to a neonatal unit. There are specialist formula milk available such as hypoallergenic hydrolyzed products. Children who are not responding well with modified food or get flare-ups with unidentified food need dietitian's advice. Parents should be explained that goat's milk and sheep's milk are not appropriate for use. Soya protein diets for children more than 6 months of age should only be prescribed on a specialist's advice. If there is severe eczema present, then immediate admission is necessary if herpes simplex virus, which has become widespread, is suspected. Generous supply of emollients should be used. Potent topical corticosteroids are then used, such as betamethasone 0.05%, occlusive dressing, and betamethasone 0.025% when slightly better, or clobetasone 0.05% is used. With itching, sleep disturbance, and incessant scratching, a 2-week course of antihistamine, such as chlorpheniramine, should be prescribed. This can be calculated in relation to age and BMI of the child. In the hospital, the specialist may choose to prescribe calcineurin inhibitors such as tacrolimus, which is quite effective. When the eczema appears to be of an infected variety, then flucloxacin or erythromycin offer good results, but if they do not, then culture and sensitivity-based antibiotics should be prescribed. Combined topical agents such as Fusobet may be helpful. Topical antiseptic products such as chlorhexidine or triclosan may be useful to reduce the bacterial count. If the patient remains unresponsive, then other hospital-based, specialist-based treatment may include tacrolimus, cyclosporin, azithromycin, and phototherapy. So the summary of medication in relation to severity of eczema means that if the patient has mild eczema, one could use emollient and a mild steroid, such as hydrocortisone or betamethasone of a low strength. And after a few days, when the condition is better, to persist with emollient and to step down or to stop the steroid topically. For moderate eczema, there should be use of emollient plus moderate steroids. Occlusive bandages, which are dry, or use of tacrolimus, if and when approved by the dermatologist or pediatrician. If the eczema is severe, then emollients should be prescribed with potent corticosteroids, usually topically, such as Dermovate or Umovate, the specialist would want to possibly prescribe tacrolimus or phototherapy. In severe cases, occlusive bandages usually do not work. In order to boost the effect, mainly in life-threatening conditions with severe eczema leading on to sepsis, there is a role for oral pulse steroid treatment. If the eczema is infected, then Fluclox or erythromycin might do the trick, but always remembering for fluid support, which could be IV and oxygenation. So what emollients and which emollients are generally available? Most are available on NHS prescriptions, but some are prescribed through an advisory committee of borderline substances. Examples are Aveeno and E45. The emollients could be cream, ointment, gel, lotion, sprays, washes, and bath additives. There are many varieties. Emollients could be plain emollients which moisturize the skin and improve the skin barrier and thicken it. If there is excessive scaling or keratin present, then urea could be used to soften the keratin and to hydrate the area. And the agent to be used is Aquadrate, Balneum Plus, Calmurid, E45, or Eucerin. Noromacrogels are topical agents which produce some sort of a local anesthetic numbing effect as well as softening effect on the lesion which has stood up proud of the surface. The examples are Balneum Plus, E45 Itch Relief Cream. Lanolin moisturizes the skin on a longer term duration with some side effects. And the examples are Hydrus ointment, E45 lotion, Oilatum Plus bath additive. Which emollients should one prescribe? There is no advantage between one type and the other. It all depends on the level of dryness and tolerance. When there is potential of infection being spread by application of a topical agent, then a pump dispenser is better. When the active ingredients are mixed, it's not a good policy. Unless when there is severe itching, urea and antiseptics needed. In general, it is a common observation that emollients are underprescribed and underused. It is strongly recommended to use 500-gram supply and to ensure that it is used up as 4 times a day and that the supply comes to an end nearly in a week to 10 days. Frequent use of emollient when compared with mild steroids suggests that emollients are 10 times better. Creams and lotions are better for erythematous, inflamed skin lesions. Ointments are good for dry skin, but they may be poorly tolerated. If a patient feels much better with a branded product, then they should continue with this through NHS prescription if possible. Aqueous cream under current research has shown a disproportionate skin reaction, so it should not be prescribed. If soap or detergents are causing problems, then emollients dissolved in boiling water and cooled will be acting in a similar way to a soap or detergent. Even if bath additives are used to moisturize, standard emollients should always be used after the bath. Emollients have some side effects. They can cause a skin reaction. Occlusive dressings can cause folliculosis. Aqueous cream produces high number of skin reactions. The potency of a steroid going up into the ladder would be hydrocortisone, betamethasone, valerate, betamethasone, dipropionate, clobetasol or Umovate, and lastly, Dermovate in the strength that is mentioned here. Remembering that advising patients to use a one-fingertip unit means a pea-sized blob, which actually comes up to 500 milligrams of the actual material. When initial diagnosis is made, a prescription should be for 2 weeks, and if the skin worsens, then to consider an alternative diagnosis or referral. I hope I have not rushed into this subject too fast, and hopefully the slides will remain available, and so would the webinar on the website if one needs some sort of a revision. I'm grateful for you to listen to this webinar, and I hope that this offers practical help in the management of your patients. Thank you very much. Thank you. Bye-bye.